Today we will start the lung tumors. By the end of this lecture, you will be able to recognize lung hamartomas and describe its pathological features, classify malignant tumors of the lung, describe the pathogenesis of bronchogenic carcinoma, and describe the pathologic features of each type of bronchogenic carcinoma and recognize their precursors. Lung metastases are very common. They appear as multiple nodules scattered all over the lung or as one large rounded or oval mass with smaller nodules. In case of large rounded mass, we call it cannonball appearance. The primary lung cancer is frequently diagnosed and a common cause of mortality worldwide. About 95% of primary lung tumors are bronchogenic carcinomas. The remaining 5% are a miscellaneous group, including benign tumors like hamartoma, squamous cell papilloma, benign connective tissue tumors, also including bronchial carcinoid, bronchial gland tumors like adenoid cystic and mucoepidermoid carcinoma, mesenchymal malignancies like fibrosarcomas and leiomyosarcomas. Also, lymphoma can occur in the lung. The most common tumors are bronchogenic carcinomas. We also describe the hamartomas and the bronchial carcinoid. We will start by hamartoma. Hamartoma is a benign tumor formed of mixture of tissue, mainly cartilage, fat, fibrous tissue, blood vessels, and respiratory epithelium in a disorganized fashion. The CT or X-ray showed solitary subpleural coin-like well-circumscribed mass about 3 to 4 centimeter diameter. This is the CT, showed a coin-like shadow, well circumscribed. Here is the mass inside the circle. This is the gross picture of hamartoma, glistening nodule, well circumscribed, showing cleft-like spaces here. A microscopic picture showed lobules of mature cartilage here, and we have cleft-like spaces lined by the respiratory epithelium, and also here. We have other mixtures of tissue like smooth muscle bundles and blood vessels. So we will shift to the bronchogenic carcinoma. It is #1 cause of death in industrialized countries. The male to female ratio decreased from 2 to 1 to 1.5 and 1. The peak of age between 50s and 60s. At the time of diagnosis, usually there is a distant metastasis or lymph node metastasis. Just to remind you about the hazards of smoking mentioned in the previous lectures in the respiratory system. These hazards causing laryngeal polyp, laryngeal carcinoma, intrinsic bronchial asthma, centriacinar emphysema, chronic bronchitis, bronchiectasis, lung carcinoma, especially squamous and small cell carcinoma. As we said, centriacinar emphysema and chronic bronchitis, we call it COPD. The pathogenesis of bronchogenic carcinoma, it's a stepwise accumulation of multiple genetic abnormalities that result in transformation of benign bronchial epithelium into neoplastic tissue. The pathogenesis of bronchogenic carcinoma, the carcinogenic factors including smoking, industrial hazards, air pollution, genetic factors, and scarring. All these factors cause early genetic change like inactivation of tumor suppressor gene B53, showing early histologic feature like squamous metaplasia, goblet cell metaplasia, and basal cell hyperplasia. Late genetic changes like mutation of tumor suppressor gene B53 and activation of oncogenes like epidermal growth factor receptor and KRAS. These late changes cause late histologic change in the form of severe dysplasia, and then lung carcinoma formed. 90% of lung carcinoma occur in active smokers. Frequency of lung carcinoma occur in heavy smokers. Cessation of smoking decrease the risk but never return to baseline. Passive smoking increase the risk to twice that of non-passive smoker. Smoking of pipes and cigars also increase the risk of bronchogenic carcinoma. Other risk factors like industrial hazards, for example, radiation, asbestos, arsenic, chromium, uranium, vinyl chloride, and mustard gas. Also, genetic susceptibility has a role. Scarring or lung fibrosis from healed previous inflammatory condition. It's a debate is whether it's a cause or a result of carcinoma, especially adenocarcinoma. The classification of bronchogenic carcinoma, we have 4 major types, histologic types: squamous cell carcinoma, adenocarcinoma, large cell carcinoma, and small cell carcinoma. For therapeutic purpose, bronchogenic carcinoma are classified into 2 broad groups: small cell carcinoma and non-small cell carcinoma, including squamous, adeno, and large cell carcinoma. Also, we can have a combined pattern of these 4 histologic types. The reason for this distinction is that the small cell carcinoma will have possibly metastasized by the time of the diagnosis and hence are not amenable to curative surgery, best treated by chemotherapy with or without radiotherapy. In contrast to the non-small lung cancer, usually respond poorly to chemotherapy and better treated by surgery. However, recently targeted therapy is available now for non-small lung cancer to target the specific mutated gene as epidermal growth factor receptor oncogenes in some types of non-small lung cancer. The histologic classification of malignant epithelial lung tumors, including small cell carcinoma, squamous cell carcinoma, adenocarcinoma, large cell carcinoma, combined adenosquamous carcinoma, carcinoid tumor typically and atypically, carcinoma of salivary gland tumors, carcinomas with polymorphic sarcomatoid or sarcomatous element, and unclassified carcinoma. The histologic classification, including squamous cell carcinoma, large cell carcinoma, adenocarcinoma with different pattern like acinar, papillary, mucinous, micropapillary, solid, lipidic, predominant, and mixed subtypes. Also neuroendocrine carcinoma, including small cell carcinoma, large cell neuroendocrine carcinoma, and carcinoid tumor. Mixed carcinoma like adenosquamous carcinoma combined small cell carcinoma. Other unusual morphologic variants like sarcomatoid carcinoma, spindle cell carcinoma, and giant cell carcinoma. We will discuss in detail the squamous cell carcinoma, large cell carcinoma, adenocarcinoma, and small cell carcinoma. And also we will describe carcinoid tumor, both types, typical and atypical carcinoid. The pathologic features of bronchogenic carcinoma. There is a firm mass near the main hilum here. We call it central mass. The cut surface is grayish-white in color with areas of hemorrhage and necrosis infiltrating the lung tissue. This mass is central. We have other site, peripheral near the pleura. So according to the gross picture, we have central mass or peripheral mass. The mass begins as small mucosal lesion if centrally. This is the main bronchus. The bronchogenic carcinoma start as a small mucosal lesion, grow to form a large fungating mass obstructing the lumen of the main bronchus, then invade the bronchial wall and go to the lung tissue. Also can have metastasis in the hilar lymph nodes or extend to the pleura, infiltrating the pleura. Another example of bronchogenic carcinoma forming large grayish-white mass infiltrating the lung with areas of cavitation due to necrosis or separation, especially with the squamous cell carcinoma. This is example of CT of lung carcinoma showing two masses. One of them showed a central cavitation. For each histologic type of bronchogenic carcinoma, you have to study the following: gender predilection, male or female, associated with smoking or not, the site, central or peripheral, the precursor, and presence of paraneoplastic syndrome and type of syndrome. We will start by squamous cell carcinoma. It's more common in male than females and associated with smokers. The precursor squamous metaplasia, dysplasia, then squamous cell carcinoma in situ, affecting the central part or the major bronchi. The mass grow intraluminally, obstructing the bronchus, leading to absorption, collapse, or secondary infection with central cavitation and abscess formation. The tumor also invades the lung tissue and can spread to the hilar lymph nodes, but distant metastasis is late. The precursor of squamous cell carcinoma. Here we have the respiratory epithelium showed focal squamous metaplasia. Then mild dysplasia occur, progress to moderate dysplasia, severe dysplasia, and carcinoma in situ. The microscopic examination of squamous cell carcinoma of the lung ranges from well-differentiated to poorly differentiated carcinoma. The grading of the tumor is based on the cytologic differentiation and number of mitotic figures. This is example of well-differentiated carcinoma. Here we have the mass consisting of groups and nests of malignant squamous cells with central keratinization. And here another example of moderately differentiated squamous cell carcinoma. We have here nests with central keratinization, and these are groups with no keratinization, so this is moderately differentiated. We will move to the adenocarcinoma. This type is more common in female and lower percentage in male. The site is peripheral, as we see here. This is peripheral mass. This is typical bronchogenic adenocarcinoma, may be associated with scarring, weakest association with smoking, usually slowly growing, but tend to metastasize widely at an early stage. The mass can be a single mass or multiple masses like this. What is the precursor of adenocarcinoma? The precursor is atypical adenomatous hyperplasia. It is a well-demarcated focus of epithelial proliferation of cuboidal cells, less than 5 millimeters, showing mild cytological atypia in the form of nuclear hyperchromasia, polymorphism, and prominent nucleoli. This is the focus of atypical adenomatous hyperplasia, and the high power shows the alveoli lined by the atypical cells, atypical cuboidal cells. We will continue the precursor of adenocarcinoma. The atypical adenomatous hyperplasia, the size is about 5 millimeter or less, may progress to adenocarcinoma in situ, about 3 centimeter or less. The previous term of adenocarcinoma in situ is bronchiolo-alveolar carcinoma. This in situ progressed to invasive carcinoma, starting by minimally invasive carcinoma, usually less than 3 centimeter, and the invasive component about 5 millimeter or less, then progressed to major or pure invasive carcinoma with invasion more than 5 millimeter diameter and any size of tumor. This is an example of atypical adenomatous hyperplasia, about 5 millimeter or less, progressed to adenocarcinoma in situ. Here we have the alveoli lined by malignant cells, epithelial cells. In the in situ, adenocarcinoma in situ, no stromal invasion involving the peripheral part of the lung in the form of single nodule or multiple diffuse nodules that may unite together, forming pneumonia-like consolidation. The characteristic feature of this in situ is its growth along the pre-existing structure, like the alveolar alveolar spaces, with preservation of alveolar architecture. This is an example of adenocarcinoma in situ. We have two types, non-mucinous and mucinous. Here we have the alveoli lined by non-mucinous epithelial cells, and the mucinous, the alveoli lined by mucin secreting epithelial cells. Invasive adenocarcinoma having different pattern like acinar, papillary, mucinous, and solid. In the solid adenocarcinoma requires the demonstration of intracellular mucin production by special stain to establish its adenocarcinomatous differentiation. This is a different pattern of adenocarcinoma. This is the acinar pattern, papillary pattern, and mucinous pattern. We will move to the large cell carcinoma. No cytological differentiation to squamous or adenocarcinoma, formed of large, highly anaplastic cells with large vesicular nuclei and prominent nucleoli, displaying scattered multinucleated giant cells, or spindle cells also may be present. Here we have the scattered giant cells in the large cell carcinoma, displaying large nuclei with prominent nucleoli, abnormal mitosis. This type of bronchogenic carcinoma has a poor prognosis because its tendency to spread to distant sites very early. The small cell carcinoma located in the central part of the lung, like the squamous cell carcinoma, spread to the hilar and mediastinal lymph nodes very early, microscopically composed of small round oval or fusiform shaped cells with scanty cytoplasm and finally granular chromatin with frequent mitotic figures. This type of bronchogenic carcinoma associated with smoking. So small cell carcinoma and squamous cell carcinoma both associated with smoking and located in the central part of the lung. The microscopic picture of small cell carcinoma formed of round or fusiform cells and little cytoplasm The high power showing the finely granular chromatin and scattered mitotic figures. Another photo showed the scattered mitotic figures and finely granular chromatin. By immunohistochemistry, we can confirm the diagnosis of small cell carcinoma using chromogranin, synaptophysin, neuron-specific enurease, and CD56. Also, we can confirm the diagnosis by electron microscope showing the neurosecretory granules in the cytoplasm of the tumor cells. To summarize, 4 types of bronchogenic carcinoma, starting with the squamous cell carcinoma, more common in males, adenocarcinoma, more common in females. The squamous and small cell carcinoma are related to smoking. The adenocarcinoma is the least related to smoking. The precursor of squamous cell carcinoma is squamous metaplasia, dysplasia, and carcinoma in situ. The precursor of adenocarcinoma is atypical adenomatous hyperplasia. Squamous cell carcinoma and small cell carcinoma located in the central part of the lung near the main hilum. The adenocarcinoma commonly peripheral. The large cell carcinoma can occur central or peripheral. The microscopic picture of squamous cell carcinoma formed of groups of malignant squamous cells with central keratinization. Adenocarcinoma having different pattern like acinar, papillary, mucinous, and solid. A large cell carcinoma formed of large cells with large nucleus and prominent nucleoli and scattered abnormal mitotic figures. Giant cells can be seen. Small cell carcinoma formed of nests of small cells with granular clumped chromatin. We call it salt and pepper appearance of the nuclei, and also have neurosecretory granules in the cytoplasm. Paraneoplastic syndrome can occur in the squamous cell carcinoma in the form of hypercalcemia, in adenocarcinoma in the form of hematologic abnormalities, no specific paraneoplastic syndrome for large cell carcinoma. All the rest of paraneoplastic syndromes can occur in small cell carcinoma like Cushing syndrome and others. Thank you.